Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. I am an associate professor of anesthesiology at the Medical College of Georgia. Today we will be talking about vitamin D and diabetes, the association that exists between this important liposoluble vitamin and this important syndrome that is becoming more prevalent in our society. Vitamin D is, as I mentioned, is a liposoluble vitamin that is found in different sources of food, like milk, for instance. And we also have the ability of synthesize vitamin D in our skin when we expose ourselves to the ultraviolet rays of the sun. So, given the fact that, especially in the Western society, our exposure to the sun is relatively limited, we depend on external sources of vitamin D. Once the vitamin D is ingested or when it is synthesized in the skin, the active forms of this vitamin D are 25 hydroxyvitamin D and 125 hydroxyvitamin D. The first process of hydroxylation happens in the liver, whereas the second one occurs mainly in the kidneys. There has been an association between the levels of vitamin D and diabetes mellitus, and some evidence have been pointing in that direction. We know that vitamin D is or has a lot of pleiotropic effects. It affects different organ systems, different metabolic pathways, and the regulation and homeostasis of blood sugar is one of those. So there are skeletal and extra skeletal effects of vitamin D. And today we are going to be discussing with Dr. Alan Sacerdote the importance of vitamin D in the context of endocrine disorders with emphasis on diabetes mellitus, the effect specifically on different complications related to diabetes. We have to understand that sometimes the association that has been found in different studies does not necessarily indicate causality. Despite all these limitations, my discussion with Dr. Sacerdote is very enlightening because he is going to illustrate the different limitations that the observational and also experimental studies have, and at the same time he's going to give some recommendations about how to overcome these limitations in the future to have a better picture that sheds light on the real association between vitamin D and diabetes. Important aspects including polymorphisms in vitamin D receptor, vitamin D binding globulin, affect the expression of disease in different individuals. When you supplement vitamin D, in some cases, the complications related to diabetes seem to improve, but it's difficult to know if this is like a cause and effect situation. We are going to discuss that more in depth. So I'm going to leave our audience with the interview. It's very interesting with Dr. Sacerdote. I hope you enjoyed this podcast, and don't forget to always leave us your comments and feedback.
Welcome to Decoding Healthcare Research. Join us as we delve into the behind-the-scenes world of groundbreaking research and the dynamic healthcare industry, interviewing top paper authors, engaging experts on industry-related topics, and exploring medical subjects that affect our daily lives.
Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. I am an associate professor of anesthesiology at the Medical College of Georgia. Today, we are going to be talking about a very interesting topic. Is type 2 diabetes, insulin resistance, and vitamin D. So we have the privilege of having with us Dr. Alan Sacerdote. He is a researcher and expert in this topic, and he actually has a very long bio. I'm going to start by introducing him. Dr. Sacerdote is a researcher who, at his retirement in 2018, was the chief of the Division of Endocrinology at the New York City Health and Hospitals in Woodhull in New York. He was the clinical professor of medicine at SUNY Downstate Medical Center and New York University School of Medicine. Additionally, Dr. Sacerdote was a professor of medicine at St. George's University School of Medicine. Also, he acted as program director of endocrinology fellowship program at SUNY Downstate. So it's a privilege to have you here, Dr. Sacerdote, and welcome.
Thank you so much, Dr. Riveros, and I appreciate the invitation.
Thank you. So we have been exploring different topics in this podcast. One of them has been diabetes mellitus, insulin resistance, and also metabolic syndrome. And we have found that there are multiple pathways that lead to these disorders. One particular factor that has been studied lately is the impact of vitamin D on these disorders. So I want to start by asking you, Dr. Sacerdote, what led you to try to find an association and to study in depth the relationship between vitamin D and diabetes?
Okay, I came to it kind of by shall we say, a back entrance to. I've been very interested in diabetes for many years, but I was also very interested in both the polycystic ovarian syndrome, especially when the link with insulin resistance and type 2 diabetes became apparent. And then more recently, with gout and non-classical congenital adrenal hyperplasia, and later classical congenital hyperplasia. I think at this time, the association of insulin resistance with the pathophysiology of polycystic ovarian syndrome is pretty well known to most practicing physicians, but the association of congenital adrenal hyperplasia with insulin resistance is much less well known. And I would say that even the people who discovered it did not really see the way to exploit it as a possible therapeutic avenue. I was asked actually to do this review article for Current Diabetes Reports shortly before I retired too. So I started working on it then and completed it actually after I had retired. So that's how I came to, review the whole topic of vitamin D and insulin resistance. It's already been, used for a number of years in treating polycystic ovarian syndrome. And then I'll show you some data we had where it was used in congenital adrenal hyperplasia to good effect.
Excellent, excellent. And from the mechanistic point of view, where where can we find the intersection between all these metabolic disorders and vitamin D?
Well, I think there's growing data that vitamin D may be an insulin sensitizer. Certainly, we do know this from in vitro studies and in preclinical studies too. And there's, I think, some increasing clinical data now too from a number of meta-analyses that show that this is probably the case in our species as well.
Yeah, and one thing that is interesting, especially when I went over the article, is that even though there is clear association, we really don't know the directionality of that association, right? Because some chronic diseases are associated themselves with low levels of vitamin D. So trying to find causality probably has been a challenge, right?
It has been a challenge, and that's, I think, one of the most important things I'd like to talk about tonight. Yeah, you see association. It keeps very bad company, low vitamin D status. It's associated with diabetes. It's associated with inflammatory and non-inflammatory markers for macro and microvascular diseases. It's associated with peripheral and autonomic neuropathy. It's associated with diabetic nephropathy. It's associated with erectile dysfunction, with diabetic retinopathy. About the only thing I could find that was bad associated with type 2 diabetes was diabetic gastroparesis. Does not seem to have an association with low vitamin D, although idiopathic gastroparesis does. So this is an issue, and the fact that we have all of these many observational studies in humans showing these associations, and then I would say at least until 2020, when we got to randomized clinical trials, most of them, the way they were analyzed and the way the studies were designed, we missed the probable causative effect of low vitamin D in this whole equation. And I think very pivotal in this regard was the NIH-funded D2D study, vitamin D and type 2 diabetes, which was run by Dr. Anastasios Pittas and colleagues, and has a lot in the literature about vitamin D and type 2 diabetes. And this was a randomized, controlled, double-blinded study using quite a high dose of vitamin D, 4,000 international units a day. And although the risk at the end of the study for progressing from prediabetes, as defined by the American Diabetes Association, and the onset of type 2 diabetes did show a reduction in risk, that risk was not statistically significant. Many of the other studies, when they did subset analysis, they did find that the most convincing results that there was actually a reduction in risk for type 2 diabetes were in those people who could be considered at high risk for type 2 diabetes, either by family history, other risk factors, or in most cases by having prediabetes by one of the definitions, although there was some variability in the definition of prediabetes used in different studies. And the other thing was the length of the study too. You need, of course, a certain amount of time that needs to be defined when you might expect to see a beneficial effect of vitamin D, if there was one. And in some cases, if the trial got to be a little bit too long, there was post-randomization confounding that took place. So even though that was taken care of very well when the patients were initially randomized into placebo and active vitamin D groups, after a period of time, patient adherence might fall off, especially as these were studies going over months and in some cases years. And one of the articles that came out after our review that I think is very important was this one, with the lead author, Dr. William Grant, which appeared in the Journal of Steroid Biochemistry and Molecular Biology in March of 2018. And the title is Why Vitamin D Clinical Trials Should Be Based on 25 Hydroxy D Concentrations. And I think this brings to mind a hazard that we have in always making the randomized control trial sort of the gold standard for clinical research, because post-randomization confounding can occur. And especially in community-based studies like these where the patient isn't being supervised, that they're taking every dose, you're not getting all the pill counts and so on. Besides this, we have genetic differences among our patient populations too. For example, we know among our Black patients, in general, vitamin D levels tend to be lower than in white, Hispanic, or Asian patients. And yet they have a much lower risk for bone disease, for osteoporosis, than white patients who have a higher vitamin D level, or Asian patients with a higher vitamin D level. So we have these variations. And so it becomes very important to actually assess that your patients are getting into and maintaining a target level of vitamin D. And this is the modification in the studies they looked. We suggested this actually toward the end of our review article, that one of the possible reasons for the initial analysis of T2D being a negative study was that they were just comparing by intention to treat whether the patients were on vitamin D or not on vitamin D. And they didn't assess at the time, although they had collected the blood to assess it. They didn't take the vitamin D levels actually achieved and maintained into consideration. So I think, when you're doing a study, you have to check that you're actually getting into the target blood level and maintaining that.
Yeah. Mhm. Absolutely, and one of the that's actually one of the aspects that you revealed in your review is that there are many challenges when it comes to designing studies, and the evidence is being built on those precise studies. So the one of the challenges, as you mentioned, is the way they are put together, and also the presence of polymorphisms. So not every patient behaves the same way. There are polymorphisms for the receptor and probably for binding proteins as well. And those factors are not usually taken into consideration for the most part in populational studies, right?
Yes. Some of these are very important too. I mean, looking at some of the polymorphisms, for example, in the gene for the vitamin D receptor. So these were identified by genome-wide association studies, and they found three of them that seem to be pretty important. One is called FOC1CC. Another was called TAQ, 1GG, and one was BSM TT. And you found that for the same amount of vitamin D being taken by the patients, and in these cases, they were supervised, that they were actually taking the vitamin D, you got different responses. For example, those patients with the FOC1CC polymorphism, you got the smallest increment in serum 25 hydroxy D levels. For the TAC1 polymorphism, you found in response to vitamin D a significant improvement in the serum triglycerides, the LDL cholesterol, the total cholesterol, insulin, hemoglobin A1C, and the HOMA-IR, which is a measure of insulin resistance. So you got significant improvements. And a similar profile occurred in response to vitamin D with the BSM1TT polymorphism. And the only difference between that and the TAC1GG being you didn't get the improvement in LDL and total cholesterol that we saw with the former. Besides that, we know that the renal status plays a role too, because they have impairment in the 1-hydroxylation of 25-hydroxy-D to its active form, 1,25-dihydroxyvitamin D. And so they can't respond as well to 25-hydroxy-D. However, in studies where they used either calcitriol, the 125 active form of vitamin D, or an active analog of 125 dihydroxy-D that bound as an activating factor to the vitamin D receptor, they were able to demonstrate benefits both on the occurrence of type 2 diabetes and, in fact, a benefit on reducing the progression of renal failure in these patients too. And that seems to be another important action of vitamin D, is its downregulation of the RAAS, the renin-angiotensin-aldosterone system, by enabling renin feedback to occur. And that activity is shown to actually be synergistic when you combine these active forms of vitamin D with either an angiotensin receptor blocker or an ACE inhibitor. So it's very interesting that you get this synergism. So we have to take all of these actions into account. There are also polymorphisms which don't seem to be quite as important in terms of prevention of diabetes, in terms of vitamin D synthesis, and in terms of vitamin D transport, especially the vitamin D binding protein. The vitamin D binding protein, by the way, probably accounts for most of the difference in circulating 25-hydroxy-D levels between Black patients and patients of other backgrounds. That vitamin D binding protein is actually lower in our Black patients, but there may really be no impact on 125 dihydroxyvitamin D, the active metabolite.
Yeah, all these relationships are very interesting, and I feel that there are two critical factors when it comes to studying the association between vitamin D levels and diabetes. One of them is the actual plasma level, right? The lower the plasma level, I assume the risk is higher. And the other one is the risk of the patient per se to develop diabetes. So let's focus on the first one. What is considered a normal plasma level of vitamin D?
Okay, it's been updated a little bit, but currently ideal level according to the Academy of Medicine now is from 30 to 50 nanomoles per liter. Insufficiency is between 20 and 30, and below 20 is considered definitely deficient for most patients. So those are considered the normal levels, but that is actually based on findings regarding parathyroid hormone. And basically, we find that most patients who keep their 25-hydroxy D levels in this range we've just described have normal parathyroid hormone levels. When you start to get below 30, parathyroid hormone starts to rise a little bit. And it may be, and probably is, that to see extraskeletal benefits of vitamin D, we have to go to higher serum.
To go higher. So let's talk about this. So if we know that there is association between low levels and diabetes and some complications of diabetes, uh, what would be expected if we supplement vitamin D? What would be the effect on these disease variables?
Well, our hope, and I think we're probably at the point we can say with some certainty now that if you maintain levels from 75 up to 125 nanomoles per liter, and here we're getting into perhaps a slightly extra physiologic range for some people. There is a significant reduction. And one of the things that I give credit to the D2D team led by Dr. Pitas was in 2000, they wrote another article for Diabetes Care, which was actually pre-specified in the D2D study protocol that they would do this at some point. They reanalyzed the data in terms of the vitamin D levels actually achieved. So they had baseline and annual vitamin D levels for as long as the patients were enrolled in the study. And they did like a rolling mean of the vitamin D levels. And when they reanalyzed the data this way, they found that patients who maintained a vitamin D level in the vitamin D branch of the study, the vitamin D supplemented branch of the study, showed actually a significant reduction to the tune of 11 to 12% over the course of the study in the incidence of new type 2 diabetes. So I think this was very significant, and it actually turned the findings of the study on its head. And I think it emphasized the point that Grant made. Unfortunately, I don't think the secondary analysis that they had done in 2020 got nearly as much attention. It was published in Diabetes Care. The initial analysis of the study as a straight randomized control trial was published in 2018. And I think that's kind of what stuck in most people's head, that it was a negative study, vitamin D didn't help. Now, 11 to 12%, it's maybe a fairly modest reduction, but I think from a public health point of view, it's enormous.
Mm-hmm.
A couple of other things too that were worth bringing out. I think they found in a couple of the meta-analyses, specifically by Zhang and colleagues and Barbarawi and colleagues too, was that leaner patients benefited more from vitamin D supplementation than did obese patients. When they looked at subset analysis, actually the obese patients did not benefit significantly, but there was quite a benefit for the leaner patients. Another thing they had looked at besides the age was, that they had to be high risk. People who were at average risk for type 2 diabetes in these two meta-analyses did not show as much benefit as people who had pre-diabetes already. I mean, in terms of future research too, I think another thing worth looking at as a high-risk group would be women who've had gestational diabetes or even gestational pre-diabetes during their pregnancies. I consider them to be a very high risk because they convert to type 2 diabetes at a rate of about 10% per year. So by 10 years after you've had gestational diabetes, almost everybody is a type 2 diabetic. You know, unless they've done some other intervention like intensive lifestyle intervention, which is very powerful, can reduce risk 55 to 60%. Metformin can reduce risk, we know, up to 30% in terms of progressing from pre-diabetes to diabetes. So although the combination of all three hasn't been tested, I think it could be a very potent, if not synergistic, at least added benefit from the three approaches.
Yeah, absolutely. And the contribution of vitamin D, as important as it is, if you don't accompany that by lifestyle changes, that effect can be overshadowed, right? And then it looks as if it didn't work. It does, but you have to fix other things at the same time, right?
Right. I think another thing that kind of confounds a lot of the interventional studies, many of them did not prohibit the people who were not randomized to vitamin D from taking vitamin D on their own. And some of them specifically allowed them to take up to 1,000 units a day of vitamin D. Plus, there's the foods that are supplemented with vitamin D or naturally contain vitamin D. Then there's the seasonal variation in vitamin D. For example, we know with multiple sclerosis, the further you were born and raised from the equator up to the age of maybe 20 or 30 years old, the greater is your risk for multiple sclerosis. And that, of course, is related to vitamin D exposure. But we know now that vitamin D deficiency and insufficiency is pretty ubiquitous. Even in Brazil, which is crossed by the equator, close to 50% of the population has inadequate serum vitamin D levels. So as people move to work indoors from, an agrarian lifestyle, the problem of vitamin D deficiency becomes more pronounced. And then as people worry about issues like skin cancer and, more use of sunblock, yes, they're protecting themselves from skin cancer, but maybe they're subjecting themselves to other risks. And they don't really realize, most of the lay public, that you only need about 15 or 20 minutes of sun exposure a day to get your maximum vitamin D synthesis going on.
Yeah, and as we understand more and more about vitamin D, we see, its effects, extraskeletal effects everywhere. And I think that has to do with the fact that in reality, vitamin D can be seen as a hormone itself, right?
Right. Another point I wanted to make too about potential hazards with randomized control trials is that you may not only be missing the benefits, you can be missing the adverse effects too, particularly if patient adherence is not there. And that's particularly true when you're getting to vitamin D levels above 100 nanomoles per liter. There is occasionally hypercalciuria, which could be a problem in terms of stone formation, and in some patients, even hypercalcemia. So this has to be monitored when we're using higher dose vitamin D. So I think that's a key point too, that, we can be blinded both to the benefits and the risks.
Yeah,
Yeah,
yeah, and yeah,
yeah,
absolutely. And definitely one of the limitations is the difficulty to design robust studies, longitudinal studies that allow you to actually follow up patients for a long period of time. And in that regard, what is your opinion about the role of Mendelian randomization studies
it's
uh, related to vitamin D?
it's a very important tool, the Mendelian randomization studies, and that was one of the reasons I had brought up about these three polymorphisms in the vitamin D receptor too, mediating its effects. And it's another way besides the randomized control trial that a researcher can infer causality. Because if you know you have a single polymorphism that is affecting vitamin D's expression and effects, by having differential effects of the vitamin D on these markers or on the incidence of diabetes, we can see that it's not just a bystander and it's not reverse causality. We can see that these polymorphisms are having different effects on the patient.
Yeah, it's like a natural way to randomize, right?
Yes.
Yeah, that's excellent. So, and before we start closing, I want to go over several of the headings of the paper because I find them really interesting. You already mentioned the effect of vitamin D on the outcome of the nephropathy, and there is a sound pathophysiological basis here related to renin-angiotensin axis. What about type 2 diabetes and mortality? Has it been studied?
It has been studied, but so far not in a randomized control trial. But we can say definitely that there is an inverse correlation between uh, mortality due to macrovascular disease and all-cause mortality and serum 25 hydroxy vitamin D. And this applies not only in diabetes, it's almost any disorder. I mean, from all my years in the hospital when I started becoming interested in vitamin D, I mean, people who died generally had low vitamin Ds just before they died. So there's definitely a correlation. Now, is it just that vitamin D is a general marker for poor health? You know, like low albumin, for example, could be. Or is it something more specific? Well, we can see in many cases it affects the risk factors. It affects insulin sensitivity. It affects LDL, total cholesterol, HDL, triglycerides. It's anti-inflammatory. We didn't mention at all, but one of the other insulin resistance associated complications, not only in diabetes, but in people who don't have diabetes, is what until recently was called non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. It's recently been renamed metabolic associated fatty liver disease and metabolic associated steatohepatitis. But there too, the fatty liver is associated with low vitamin D levels. Uh, so all these things now that I think are pretty well convinced that vitamin D does have some preventive effect on type 2 diabetes and some beneficial effects on inflammatory markers. For example, high sensitivity C-reactive protein has been shown to be lowered by vitamin D. Although other inflammatory markers like TNF alpha, which is highly associated with insulin resistance, and interleukin 6 did not really show any significant change. But again, the doses may not have been high enough. We don't know from these studies what vitamin D levels were actually achieved and maintained for the duration of the study. So I think a lot of these studies, in terms of complications of diabetes, have to be repeated with the randomization and comparison of the groups that maintained a high vitamin D level and those that did not. One other very interesting thing that, still probably needs a little bit of explanation. In those people who were not randomized to vitamin D supplementation in the D to D study, those who did attain the high levels of vitamin D through sun exposure and through their own dietary and supplement exposure, levels of 75 and above, did not show the same reduction in type 2 diabetes incidence. It was a little bit puzzling. And what Dr. Pettis theorized is that probably once a year was not enough to monitor them, that they were having seasonal dips in their vitamin D during the fall and winter, I should say fall and winter and spring months when vitamin D is at its lowest. And their adherence to supplements, was probably variable. In general, I think in studies, adherence gets better as they get closer to the sampling time. I've seen that in clinical practice too. My diabetic patients, yes, their blood sugars get better as they get close to the visit or when they go to the lab, but the A1C will show us that they haven't been as adherent as they look for a few days before their visit. So that's what he theorized was the reason for that difference, why the same average vitamin D level wasn't giving you the same protective effect.
Yes. And I think the way you were able to capture all this information is so comprehensive. I dedicated myself to look for papers, regarding this type of information, and this is definitely by far the most thorough of all the papers. And before we close, I would like to hear from you what would be your advice for researchers, what considerations they should incorporate for future research studies so that we can clarify better the association and the causality between vitamin D and diabetes mellitus in diagnosis and complications.
I think the most important thing is the point Dr. Grant and colleagues made in their paper that you must include the levels and analyze the benefits and adverse effects according to the vitamin D levels actually achieved and maintained. So you have to be sure you sample for that, sample frequently enough, probably at least every 6 months. You have to use high enough doses, and I think 4,000 units or even maybe a little more, 5,000 units would be good. Becomes more difficult and more expensive if you try to keep everybody with the same polymorphisms. But if you have a lot of money to do the study, a good grant, it could be done that way. So I think those are the most key things.
Excellent.
I would like to just kind of
Yes.
go to our slides now. If
Absolutely. Let me share the screen.
Okay. So this was a patient that our surgical patient service had asked us to see. This was a gentleman with uncontrolled diabetes, type 2, and a lower extremity infection, which is why he was on the surgical service. Our endocrine fellow, who was one of the best fellows we ever had, Dr. Millet Louis, She had examined this patient very carefully and found something that the surgical intern had missed when they did their physical, which was this patient also had hypospadias and a micropenis. So we became interested not only in monitoring vitamin D, which we came to do at some point on all the patients we were asked to see, but in checking this patient for non-classic or classic adrenal hyperplasia. And we found in a much earlier study we had done in the early 1990s that just about everyone with type 2 diabetes and most people with autoimmune diseases actually have non-classic adrenal hyperplasia. And what we found was this patient had a sky-high 11 deoxycortisol level at baseline, which was um, uh, in the range, together with the physical findings of somebody with the classical or severe form of 11 hydroxylase deficiency. And because he was vitamin D deficient, his initial vitamin D was only 12 nanograms per ml. We started to supplement him, in this case with vitamin D2, which is what we had on formulary, ergocalciferol. And you can see that just by day 9 of this therapy, his 11 deoxycortisol had come down dramatically. And by day 17 of therapy, shortly before he was discharged, the 11 deoxycortisol had come down actually into the lower part of the normal range. So we see here an effect of vitamin D quite dramatic. We were assured of his compliance occurring in quite a short time, that basically we hormonally normalized his adrenal function. If we could go to the next slide down, Efren. Yeah, and here, this slide I'll walk you through. It's initially a kind of strange way of presenting the data. But on your left, you see the 11 deoxycortisol levels in the dark shading. And in the light gray shading, you see the 25 hydroxy D level. And you can see that as the 11 deoxycortisol level is going down, the vitamin D is going up. And then when we get to the issue of causality, I think the next slide is very interesting. Okay. This was a patient, trying to remember exactly why they asked us to see him, but he was also on the surgical service, and he had recently had a pretty extensive large bowel resection for colon cancer. And he was with a colostomy, and for some time they had to put him on TPN, total parenteral nutrition, which being intravenous doesn't really give you a way to give the patient vitamin D. Now, I know the columns are a little hard to see. The blue columns are this gentleman's 11 deoxycortisol levels, and the yellow columns are his 25 hydroxy D levels. So when we saw him initially, he'd been maybe a week or so into hyperalimentation, and already his 11 deoxycortisol level was a little bit elevated at 62. Normal for an adult male is 37 and below. And as he continued to be vitamin D deprived, several weeks later at the middle column, we see the 11 deoxycortisol level has gone up And actually, the vitamin D, it's hard to see because it's a short column on the graph, but it's going down further. And in the third column, all the way to the right, the vitamin D level is about where it was, but it's been there for a much longer time. And the 11-deoxycortisol level has gone way up. And this actually, I think, points to a causative role of vitamin D deficiency in the actual expression of this form of non-classical adrenal hyperplasia. So here we've seen both the amelioration in the first two slides and the causation of vitamin D's deficiency in the last slide. So I just wanted to share that with you and with our listeners as a kind of interesting thing. And this was based on our being convinced that vitamin D is an insulin sensitizer. And we've had this experience with other insulin sensitizers, including metformin, the glitazones, weight loss, exercise, and also with the Ayurvedic herb ashwagandha, which has been shown to be an insulin sensitizer as well. And all of them seem to improve both classic and non-classic adrenal hyperplasia.
Yeah, it's super interesting, and this whole thing puts the vitamin D as an extra tool in our armamentarium when we tackle insulin resistance, right? So if we make it part of an integral plan, I am sure that the results are going to be more impressive than if we don't use it.
Yeah, I think in congenital adrenal hyperplasia, the standard of care for many years, and we owe a lot to the work of Dr. Maria New and our colleagues at New York Hospital, Cornell, has been the use of glucocorticoids, and in the classical forms, also mineralocorticoid. But however careful you are, you do get some side effects from these steroids. So the patients, some of them do get osteoporosis. You do get some growth retardation. You do get some hyperglycemia. And using vitamin D or some of these herbal things or metformin, can avoid a lot of those complications of treatment.
Yeah, that's super interesting, and I think that brings us to a close. And before we finish, I want to thank you, Dr. Sacerdote, for your kindness and for sharing all this knowledge with us. This is a topic that is very deep, and the way you presented it was really enjoyable, and I learned a lot, and I'm sure that our audience is going to enjoy it as well. So thank you very much for spending this time with me here.
Thank you very much, Efren, for the invitation. And before I leave you, I just did want to acknowledge and thank our co-authors on this review article, Dr. Bahtiyar, my long-term colleague, Dr. Lokshin, one of our residents, and Dr. Polomi, our resident and later one of our endocrine fellows at NYU. And our editor, Dr. Harold Lebovitz, who asked me to do the review article. Thank you again.
Perfect. Thank you. And for our audience, the link to the paper is going to be found in the description of the video. And don't forget to leave us your feedback. See you in the next episode.
Thank you so much for tuning into this episode. If you enjoyed it, please don't forget to give us a thumbs up and share it with your friends and family. Make sure to subscribe to our channel and hit that notification bell so you never miss an episode. If you have any questions or thoughts about today's topic, we'd love to hear from you. Feel free to leave your comments down below. For more information and references related to today's discussion, you can find them in the video description below. We appreciate your support and look forward to having you back for our next episode.